Welcome, everyone, to Creating a Family. Talk about adoption and foster care. I'm Dawn Davenport, your host, as well as the director of Creating a Family. And today we're going to be talking about evaluating risk factors in domestic infant adoption with Dr. Dana Johnson. He is a professor of pediatrics at the University of Minnesota, where he co-founded the Adoption Medicine Program in 1986. Over the course of his career, he has reviewed the medical records of over 20,000 children and counseled potential adoptive parents on the likely medical needs of these adoptees. He is a dad by both birth and adoption. Welcome, Dr. Johnson, to Creating a Family, or I should say, welcome back. We have talked before, so welcome to Creating a Family.
Thank you so much, Don. It's just wonderful to be with you again.
Today, we're going to be talking about evaluating risk factors common to domestic infant adoption. So I've broken this down into the common risk factors that we see, and we'll just talk about them one by one. Let's start with lack of prenatal care. That is often something that we see with expectant moms. So why expectant moms who are considering making an adoption plan? So why do expectant moms who are thinking about adoption often have limited prenatal care?
Well, I think some of it may be due to the fact that they often don't have health care benefits. They are either employed in an occupation which doesn't offer them, or they're unemployed. And I think many don't understand that most states have programs to offer prenatal care for free to pregnant women within their states. I think the other couple of issues include that they may not want to acknowledge the fact that they are pregnant. This is particularly true in younger girls who don't want to confront their mother with an unexplained pregnancy. And maybe some people just want to put it off as long as they can without acknowledging it. So they often come into prenatal care at a later date. And also for women who are drug and alcohol dependent, life is just so disorganized that it just may be too difficult to seek out prenatal care with the addictions that they have.
So what is covered in typical prenatal care, and how might a lack of prenatal care impact the baby?
Well, when a physician or other health professional approaches a pregnant woman, they have to realize, and they do realize, that they're taking care of two individuals. They want to make sure the mother is healthy and has a normal pregnancy, and they want to make sure that the baby is also doing well. So in terms of the mother's health, they want to look at underlying conditions. Does the mother have diabetes? Does she have high blood pressure to start with? What is mother's nutrition? They want to counsel her on avoiding drugs and alcohol and other substances that might affect the baby. They want to make sure her mental health is okay. Is she safe at her home? And they want to make sure that the mother remains healthy. So they do ongoing regular checks to make sure blood pressure is okay, there's no protein in the urine, weight gain is not too much or too little, blood sugar is not too high, and look at the underlying issues of adversity, which will increase risk aside from the economic status of individuals. For instance, we know, particularly in the current era, that women who are Black, despite being well off and of upper economic status, will still share some of the high-risk pregnancy issues that women of lower economic status have, simply because of long-term racism and adversity due to that. Mm-hmm. In terms of the infant's health, you want to make sure the baby is growing normally, the baby's not too large or too small. Are there any obvious congenital malformations? So a regular ultrasound is done to make sure everything is going well. And there are other monitoring techniques. If there's any question about whether the baby's doing well, there are ultrasound techniques that allow a healthcare professional to assess the well-being of the baby in utero, and also external fetal monitoring can do that as well. So there's lots that can be done to make sure the mom is doing well, and to make sure that the baby is growing and developing normally.
All right. Another common risk factor in domestic infant adoption is prematurity. What causes a premature birth?
Well, there are many causes that we know are associated with delivering babies prematurely. So we can look at a very common thing, which is that multiples, twins, triplets, quadruplets, often deliver early because the uterus gets very, very large from having more than one occupant. And the larger the uterus is, the more likely they are to go into preterm labor. We can also have abnormalities in anatomy. Sometimes the uterus is smaller because it's split in two. That can lead to preterm delivery, or other times we see the exit to the uterus or the cervix be lax or weak, and that can lead to premature cervical dilatation and premature delivery. We often have maternal illness that can be a factor. Diabetes can threaten the mom's life, hypertension, the development of a disorder called preeclampsia or eclampsia, which is associated with high blood pressure and protein in the urine, can also impact the mother's health and threaten her life. And sometimes premature delivery is necessary to save the mom's life in that kind of a situation. We also know that infections of the membranes surrounding the baby or the amniotic fluid can also initiate early delivery. We also know that certain drugs, particularly things like vasoactive drugs like methamphetamine and cocaine, can also lead to earlier delivery, and opiates can as well because of the lifestyle, lack of prenatal care, poor nutrition, etc., that goes along with the use of these drugs. And also very young women, less than 17, or older women, older than 35, will have a higher chance of delivering prematurely.
So, what are the risks with a premature birth based on the degree of prematurity?
Well, I think that you can sum it up by saying that the earlier the baby is born or the smaller the baby is born correlates very nicely with risk factors. So a term baby is any baby beyond 37 weeks up to 42 weeks, and that's where we have our standard developmental outcomes. Late preterm babies between 34 weeks and 37 weeks will have slightly increased risk, but generally do almost as well as full-term babies do. Below 34 weeks, we have a higher risk, and then below 26 weeks, we have a much higher risk of long-term problems. And the same with less than 1,000 grams, lots of risk. Less than 1,500 grams, somewhat of a risk. Less than 2,500 grams, about 5.5 pounds, somewhat increased risk.
When you talk about risk, what do you mean? So, we're talking about a small, early baby. Yeah, what are the risks for that baby long term?
Well, there are a lot of risks that we can talk about in neonatology, and this is what I do for a living, so I'm very familiar with these issues. Some babies are born and escape totally unscathed. They're absolutely normal kids with none of the complications that we see with prematurity. But there are other babies that seem to bite off a bigger chunk of the problems that we see with prematurity and have lots of different issues. So the range of issues include, and again, the risk of these goes up as the baby gets smaller and earlier in gestation. Intraventricular hemorrhage, this is bleeding on the inside of the brain that fills up the fluid-filled areas. This can cause hydrocephalus or water on the brain, requiring a shunt, or it can actually damage parts of the brain, the motor tracts surrounding the ventricles. We have a vasoproliferative disease on the eyes called retinopathy of prematurity that can lead to diminished vision or blindness. We can see delayed motor development, and cerebral palsy is one of the conditions that we see with that. Chronic lung disease and asthma also occur, a higher increase of hearing problems. And then we see the signs of early brain damage or maldevelopment can occur in any child who experiences adversity in early life while their brain is doing most of its active development. And these can include cognitive impairment, learning disabilities, emotional and behavioral problems, attention problems, and even autism. And finally, we can see growth restriction. These kids can remain small for a longer period of time. However, I would add to this long list of potential problems. When we look at the studies, what we see is that as time passes, some of these issues get less and less important. And in fact, when you look out 10 or 20 years after a premature baby is born, the thing that seems to be the most consistent in the studies is that the quality of the family that the kids go into, how much attention, how much health care, how much love and nurture these kids get is the most important factor in terms of their development. So when I talk to parents who are adopting preterm babies, I always emphasize that they really do have a major role to play in the outcome of these infants. This is not a fixed in stone kind of problem that we see in these kids. Yes, they do have issues. It's more common to see longer term issues in very small babies or very premature babies. But the fact that they can provide love and attention to these kids makes a huge difference in their outcome.
Excellent. Let me pause and remind folks that this show is underwritten by the Jockey Being Family Foundation. Since 2005, Jockey Being Family has been a leader in providing post-adoption support to strengthen adoptive families for successful futures. Jockey Being Family connects adoptive parents and children with education and resources to help prevent failed adoptions. They believe one failed adoption is one too many. You can connect with Jockey Being Family on their social media platforms at Facebook and Instagram, where they go by @JockeyBeingFamily. All right, another risk factor, one that we do talk about a fair amount, is prenatal exposure. I have divided prenatal exposure into, so we're going to talk in this order: alcohol, opiates, and then a list of other substances that can be abused during pregnancy. Let's start with alcohol. What are some of the, first of all, let's say, what are some of the red flags that a mom might have abused alcohol during her pregnancy? Because often for an adoptive parent, adoptive parents or pre-adoptive parents don't know. So what are some of the red flags?
Well, you're right, Don. It's often very difficult to determine whether or not moms have used alcohol or other types of drugs during the pregnancy. But I think we can look at what's called the 5 Ps, which is finding out whether her parents had problems, whether her peers have any problems with substance abuse, and this can go for anything, like not just alcohol, whether their partner has had problems with substance abuse, whether there have been past difficulties in the mom's life due to substance abuse, and whether or not they've used it during the past month. So when we talk to moms who were wondering whether they're using substances, and we do this for every mom during their first prenatal visit, we don't ask them if they use drugs or alcohol. That's often pejorative. People know that they shouldn't be doing that, so they often protect themselves and don't acknowledge that. Just be very forthright and say, how much alcohol have you used over the last month? Because people do drink. And they're probably going to be more likely to be forthright if you just phrase it in that kind of a fashion. You want to know how much, the type of alcohol they're using, and how often they're using it.
So those are the questions that you would ask. All right. Does the degree of impact differ depending on when in the pregnancy alcohol was consumed? And we should also discuss the quantity. And I know that we say, and of course it is true, that there is no known safe amount of alcohol. But does the degree of impact differ depending on how much alcohol is consumed and when in the pregnancy?
The opinion of most healthcare professionals at this time is that, again, like you said, there's no safe amount of alcohol to use, and there is no safe period of pregnancy in which to use alcohol. The effects may be different. So, for instance, the full facial features of fetal alcohol syndrome usually occur if mothers use alcohol in the first trimester during pregnancy. However, brain growth occurs throughout the pregnancy, body growth occurs throughout the pregnancy, and these can all be affected by alcohol, irrespective of when moms may use it during the pregnancy.
So what are some of the let's say, short-term and long-term impacts of alcohol consumption throughout the pregnancy?
Well, first of all, fetal alcohol syndrome or fetal alcohol spectrum disorder, you can see abnormal facial features, and these include a thin and flat upper lip, an absence of a philtrum, which is that groove between the base of the nose and the upper lip, and small eyes. They can have a smaller head size. They can have low body weight. They can be short. And in the newborn period, they can have sleep disorders through the first year of life. The most of the cognitive problems that we see in alcohol-exposed children begin to show up as they get into school-age years. And we can have hyperactive behavior, poor coordination, poor memory, difficulty in school, especially with reading and math, other learning disabilities, speech and language delays, low IQ, and poor executive function, which includes reasoning and judgment. There's not a lot to identify a child in the newborn period, oftentimes, who have been alcohol exposed. Sometimes you can pick out kids with full facial features of fetal alcohol syndrome, but the facial features are much more prominent when kids get to be a year and a half to 3 years of age, when they become much more classic, and when kids start having school problems later on.
And I think it's also important for parents to realize that the absence of the facial stigmata or the facial features associated with alcohol exposure are not indicative of the fact that if the child does not have the facial features, it does not mean that the child has not been impacted.
No, that's absolutely true. And we tell that to families all the time when we look at the facial photographs and say, well, it looks like the facial features look within the normal range, but we cannot tell you how the brain has been affected.
Mhm. Let me say that there are various resources available to learn more. Creating a Family has a lot of resources specific to alcohol exposure that you can learn more about how children and adults along the fetal alcohol spectrum disorder learn and function. So that would refer you, we have a number of courses on that as well. All right, another substance that we certainly are hearing a lot about is opioids. And let me just list a number of opioid drugs because I think sometimes we don't always know what these opioids are. Codeine, hydrocodone, which is Vicodin is an example, morphine, oxycodone, which Oxycontin and Percocet are examples of. Hydromorphone is another one, heroin, methadone and Suboxone, fentanyl. So all of these are opiate drugs. Did I leave out any obvious ones, Dr. Johnson?
No, that's a good list.
Okay, good. Well, or bad list, as the case might be.
Bad
But
list,
anyway,
exactly.
yeah. All right. So let's talk about opioid exposure. Does the degree of impact differ depending on when in the pregnancy the opioid was used, and the quantity? Is taking one pill the same as routine exposure, or taking hitting up once, depending if it's legal or illegal drugs you're talking about? So let's talk about timing and quantity.
Well, certainly low amounts of opioid use during pregnancy prescribed for pain is probably not going to affect the baby very much. However, chronic usage, especially if it's close to the time of delivery, will certainly predispose a child for opiate withdrawal syndrome. Let me break it into two categories.
Okay.
So there's long-term effects of opioids or any other illicit drug, and we don't know when in the pregnancy those effects may occur. What I would say is the general rule of thumb is if it's a small amount of usage, strictly regulated by a physician of a legal usage of an opioid during pregnancy, it's very unlikely, especially if there's a good rearing environment for the child, to cause long-term mental problems or behavioral problems. However, what the other thing that we see, and we know what happens, is this whole issue of withdrawal of opioids that has placed so many children in medical care units after birth and in foster care after birth, We know that chronic usage of opioids during the pregnancy, especially if that usage is close to the time of delivery, we know that that can cause opiate withdrawal syndrome. And that's when we see the neonatal abstinence syndrome due to the withdrawal of the medication after delivery.
I think a common belief in our society generally, but also pre-adoptive parents, is that if a child is not born dependent or with a diagnosis of neonatal abstinence syndrome, NAS, that means that the long-term impacts will not be there. That being born addicted is an indicator that the child, or born dependent is an indicator that the child will have more impact, and being born without being dependent means the child will not be significantly impacted. Is that true?
Well, I think it depends on the drug because some of the illicit drugs, not the opioids necessarily, but for instance, cocaine and methamphetamine really don't have a lot of problems in the neonatal period. What I would say about opioids, where we do see more problems in the neonatal period, is that if usage was small enough that they don't exhibit withdrawal, then we know that certainly the usage close to delivery has not been greater, and those kids may not have as much of a risk. But we really don't know that. We have not done the long-term studies to show whether or not opioids taken early in pregnancy or in the middle of pregnancy and then discontinued are safe and don't have any effects over the long term in babies. So I would say that if a baby has not exhibited withdrawal, that's a good sign. But I would not be sanguine about it. I would watch those kids very carefully if we know that they've been exposed to opiates in utero, just to make sure that we identify any issues early and can intervene at an earlier stage.
So, of the opioids that we have mentioned, we're going to talk about the other drugs here in just a sec. But of the opioids, is there a difference in impact that you see depending on the drug that was involved, or whether it was a legal or illegal drug?
Well, certainly the drug has an effect. I mean, there were there's a wide range in how powerful opiates are. So on that list of yours, codeine would be a pretty weak drug, and one we would not see a lot of effects for. However, fentanyl, which is an enormously potent drug, we might see more of an effect. So yes, it does make a difference what the mother was using. Again, we don't know the long-term effects necessarily, but certainly the effects on the baby in terms of withdrawal will be more severe the more powerful the opiate will be. So the second part of your question, whether it was illicit or prescribed. Well, there are some drugs that can't be prescribed, such as heroin, which is a very powerful opiate. But there are very, very powerful opiates that can be prescribed, such as the oxycodone group, and those can be used legally or they can be used illegally too. So the effects are going to be the same. If they're abused, not taken under a physician's guidance, it's probably more likely that those children are going to exhibit withdrawal effects. But the drug is a drug, whether it's illicit or non-illicit. It can cause effects in the baby.
Well, that raises the issue of medical treatment for addiction disease using methadone or Suboxone.
Yes.
And we see a lot of concern for a mom has been seeking treatment. She is following the protocol. So how does methadone and or Suboxone impact a fetus or a baby after birth?
Well, again, we're not sure about the long-term effects. If you look at the literature, most of the studies are very short-term. They involve relatively small groups of individuals, and they may not have appropriately taken care of some of the other confounding variables, such as whether the mom, took good care of their child and provided nurturing care to them. So what I would say is that there's a potential for long-term issues. And tell me again what the question was.
Well, the mom will also have been most likely
Yes, yes,
taking
yes.
the
Okay,
methadone and Suboxone up through and through delivery, so it is not unusual
right.
to see those
We're gonna
children
we're
born
gonna we're gonna
dependent.
see those kids born and likely experience neonatal withdrawal syndrome.
Hmm.
So we know that those kids require a lot of attention during the first few months of life. We want to make sure that they're nurtured. We want to make sure that their needs are attended to and that they are not physiologically compromised by having that medication withdraw too quickly from their system.
Hmm.
Those are the kids who we would follow very, very carefully during the first year of life and make sure that they are in an early intervention program so that early effects can be noted and that these kids can go into occupational therapy, speech and language therapy. And those are the kids, if they're adopted, that I would make sure that those children get a full neuropsychological evaluation before they get to school, simply to find out what their areas of strength and weakness are. One thing to remember about programs, it's great to be in a methadone program. Individuals in methadone programs are routinely screened for the use of other drugs. We know that they are generally get a better chance of getting prenatal care and that their outcome is better than if they are out randomly using drugs. But we also know that people in, for instance, methadone programs have a high incidence of exposure to other agents. 75% of them smoke, so they're exposed to nicotine. 40% use alcohol, so there's a chance of alcohol impact on the developing nervous system too. So all of these are reasons why these babies need to be monitored, not only in the newborn period, but over the course of time to make sure that if any problems occur, that we are able to get them into therapy earlier rather than later, because we know that the earlier intervention begins, the more profoundly helpful it is to these kids.
All right, you've mentioned earlier methamphetamines and
Yep.
cocaine. So what do we know? Those have we certainly have had more research because they've been around
Yeah,
longer,
exactly.
if for nothing else. Yeah. So what is the research showing for exposure to meth and cocaine in any of the forms that cocaine presents?
Those who have been around a while, and that's both of us, recognize the big cocaine epidemic that occurred in the 70s and the 80s. And so consequently, studies looking at the effect of cocaine exposure during pregnancy began a fairly long period of time ago. So we have a long track record of following these kids. So one of the best studies was started in 1993. And we know that in terms of low birth weight, using cocaine during pregnancy is associated with about a 1 pound decrease in birth weight. They're delivered a little bit earlier, about a week. For the newborn, there really wasn't very much withdrawal noted. There were some subtle effects, but probably nothing you would pick up unless you were doing a detailed scientific study. And actually, the long-term effects of cocaine exposure, when you control for all the other variables that go into raising a child, diet, whether there was drug use by the parents, whether it was a nurturing environment, the socioeconomic status, all those factors factor into how the outcome is. When you control for those, the findings have been pretty inconsistent and quite subtle in terms of the effect of cocaine alone. And those fall into the areas of subtle learning disabilities. So despite the fact that we were very, very concerned about cocaine, it didn't turn out to be as potent as we initially thought. Now, that's not to say that one should use cocaine, because cocaine is associated with a lifestyle that does not predispose to a good developmental environment for a child. But if you're looking just at the drug, there wasn't very much effect. So in looking at things like methamphetamine, which came after cocaine, those
Hmm.
studies started in 2002. We have a fairly good long-term data from that particular study. Birth weight's affected a little bit, about 200 grams, so about half a pound. Earlier delivery, a little bit more than a week. Again, with newborns, not really any abstinence syndrome as we would see with opioids. And in terms of long-term, we don't have really, decades of data about that, but at least at 1, 2, and 3 years, there was no difference in mental development. So, the effects of cocaine and methamphetamine are more likely to occur during the actual pregnancy. And we can see these are very vasoactive compounds. We can see abruption, which is early detachment of the placenta. We can see infarcts in the brain in those individuals. So they can be major effects. But in terms of long-term effects, if a fetus emerges unscathed, it doesn't seem to have a long-term effect.
What about marijuana? Now that so many more states have legalized marijuana, I would assume we are seeing more pregnant women using marijuana. What do we know about the impact on the fetus and the baby from a mom smoking marijuana during her pregnancy?
Well, again, one of the problems is that we do not have very, very long-term studies on marijuana exposure during pregnancy. And I would agree with you, this is a huge problem. In my practice, we have a very high percentage of our moms that are using marijuana during their pregnancy and even using marijuana while they're breastfeeding their babies after pregnancy. So this is going to be a major issue for us to face in the future, and what we need are better studies. The studies to date don't show very much effect. That's not to say that we're not going to see longer term effects. These are very potent molecules, and we know that it affects us as individuals if we choose to smoke marijuana. And it's I think, silly to think that it may not affect babies at all, simply because we don't have the data early in life. So I would not advise smoking marijuana, but we don't have any data at present to show long-term effects.
And what about hallucinogens like ecstasy and others? Do we know anything about how they might impact the fetus and or baby?
Well, the data on ecstasy is limited as well. Right now, we don't see very much difference in the newborn period. For instance, we don't see a withdrawal type of behavior with ecstasy. There are some subtle effects that have been described: poor motor quality and lower milestone attainment in the first months of life. And that seems to be dose dependent. The higher the dose, the more potent that seems to be. And fine in gross motor delays in the first couple of years of life, but we really do need more follow-up studies to know what happens to these kids over the long period of time. And I would add, when you're looking at follow-up studies of anything, this includes prematurity, this includes drug exposure, this includes alcohol exposure. These are very difficult studies to do. There are a lot of small studies. There are a lot of studies that are published because they show an effect, but they may not have been very well done. What you want is long-term prospective studies where they enroll the child at the time of delivery, they follow these kids on a regular basis, and they also follow the other factors in that child's environment that can impact development. And those are very, very difficult and expensive studies to do. But those are the ones that really tell us what happens.
Yeah, and from an adoptive parent standpoint, one of the things that they are most curious about is how do we separate the impact from a child being raised in an environment where parents are still abusing drugs versus children who are removed from that environment. And it could also be because the parents got clean, so they then maybe the family is higher functioning, but it could also be that the child is removed because they are placed for
Yes,
adoption. So from an adoptive parent standpoint, that's of great interest because that would be the scenario that they're considering, of course,
exactly.
is that the child would not be in an abuse in a family that is still abusing drugs.
Well, and this is what I come back to, and why I like working with adoption so much, is because the adoptive family, the commitment of adoptive parents, whether they're adopting from abroad or whether they're adopting domestically or whether they're adopting from foster care, is so extraordinary that, this is the ideal situation for most kids to go into, because they get the love and attention they need. Parents are devoted to their kids, and they provide the environment that is optimal for a child who may have risk factors in which to develop. So I tell adoptive parents that, going into a functional, nurturing environment never hurts a child. It almost always benefits. It doesn't help everything. There are some things that don't seem to be affected by nurture, but there are other things that are affected hugely by a nurturing environment. So a child will always be better off being raised in a nurturing environment, whether in a birth family or whether in an adoptive family. And what I tell adoptive families, because almost every child has a risk factor now when they go into an adoptive family, all children basically are special needs now, is that they have an enormous effect on the outcome of their children, and that the outcome is probably going to be better than many of the literature studies would suggest, because most of those studies were done when those children remained within their birth family, where they did not necessarily have the optimal opportunity to develop in a good environment.
All right. This show is brought to you by the support of our partner agencies, and these are agencies that believe in our mission of providing pre- and post-adoption education, training, and support for families and for the professionals who support these families. One of these partners is Adoptions from the Heart. They were founded by an adoptee, and they are celebrating 35 years of bringing families together through adoption. They're a full-service domestic infant adoption agency specializing in open adoptions. You can see adoptive parents and birth parents share their stories on their Adoptions from the Heart TV, AFTH TV, which airs Tuesday mornings. You can follow them, Adoptions from the Heart, on Facebook and YouTube to catch every episode. And we also have Children's Connection. They're an adoption agency providing services for domestic infant adoption, as well as embryo donation and adoption throughout the U.S. They also provide home studies and post-adoption support to families in Texas, and we thank both of them for their support. All right, we've talked about prenatal exposures and as being in prematurity and lack of prenatal care. But another risk factor that adoptive parents often face when deciding and evaluating a match is mental health issues. So what is the genetic connection for the following mental health disorders? Because as it often presents from an adoptive parent standpoint, is they are a expectant mom has chosen them, or the agency has matched them, and they, in the mom's history, either her history or her parents' history or her immediate family's history, there is evidence of a mental health diagnosis. So how heritable are the following mental illnesses? Let's start with anxiety disorders, which would include panic disorders, obsessive compulsive disorders, phobias, and things like that.
Let me step back a little bit and talk about the whole issue
Sure.
of mental illness in the family's history.
Excellent.
First of all, and we see this more of a problem in international adoptions, where a diagnosis comes across that the mother had schizophrenia. But yet we know that the psychiatric diagnostic capabilities within that particular country are not necessarily the best. That's not such an issue here in the United States, where we have better mental health. But still, I think when you see that information within a referral, that the mother or other relatives may have a mental health diagnosis, I think you always have to ask, is that really true? And try and find out as much about that as possible. Certainly mental illness is very common. 20% of people will have a mental health diagnosis. But oftentimes, people impose mental health diagnoses indiscriminately on people simply because of their behavior or their lifestyle. Mm-hmm. And therefore, I think you always have to look at that diagnosis and say, how was that diagnosis made? Is that diagnosis true? Is this something that I worry about in terms of inheritability? Second of all, we've learned over the last 20 years that not only is there a genetic predisposition for a mental illness, but that genetic predisposition works alongside of the environment in which the child is raised to lead to the development of full mental illness. So for instance, there have been several genes that have been associated with depression in adult life. But we know that some of those genes are activated by early experience. So if a child grows up under adverse conditions, those genes are much more likely to be expressed. But if that child grows up under conditions of nurture, the likelihood of depression is much, much less. So you always have to consider, again, what that child is going to be going into, the environment that they're going to be going into. So you may have a child whose parents have been severely depressed. You may be wondering whether or not is that child going to grow up and have depression. Well, if that child enters your family as an infant, you are going to provide protective factors for that child so that they're much less likely to become depressed. However, if that child comes into your family when they are 7 or 8, after being in foster care with multiple placements, enduring child abuse or neglect, that child is much more likely to have expression of that gene later on in life. Mm-hmm. So it's a complicated issue to look at how likely a specific mental illness is going to occur within the context of adoption.
Oh, and let me throw one other factor in there that I don't think you mentioned, and that is it goes back to the same issue we were talking about when we were talking about drug abuse. If a child is raised by a parent with anxiety disorders or depression or schizophrenia, that impacts the child and obviously changes the environment.
Exactly.
And makes it more likely that the gene will be expressed as well. And since you're removing the child from that, if the child's being placed for adoption, then that also, it has to be factored in.
Now, there have been, in terms of looking at the genetics of mental illness, adoption studies have been very important in trying to figure this out.
Mm-hmm.
So, the whole 12 studies.
As well as twin studies, I'll throw that out there. Yeah, I'm absolutely fascinated by the heritability of many features, including mental illness, and twin studies and adoption studies have been very important.
So, for instance, looking at the major affective disorders like schizophrenia and bipolar disorders, if you're an identical twin and one of your twin has schizophrenia, you got about a 50% chance of having it. Now, that's a high percentage, but it's not 100%. So environment has something to do with that. With bipolar disorder, you got about a 70% chance if your twin has it. So it has some environmental, but it seems to have a stronger component. If you have, if you are adopted out of that environment, the best studies that have been done have been done in schizophrenic families. So if you have a mother who's schizophrenic, your chances of being schizophrenic is about 15%. And bipolar disorder, it's about the same, it's about 20%. Now, there have been studies that have taken infants or looked at infants who have been placed by mothers with a diagnosis of schizophrenia into families, both who have parents who might have schizophrenic type of disorders and in normal families. Now, the best, these are, again, difficult studies to do. You need a lot of individuals with schizophrenia because not very many places for adoptions. You've got to have very, very long follow-up period. So you're going to find variability in some of the studies that are out there that say that, well, it doesn't really help, and some it does help. The best one that I saw came from Finland. They have a national health service. They can follow these records for many, many years, and they've done this. They looked at mothers who were schizophrenic that had a real diagnosis, done according to good psychiatric practice, and placed, their infants into families. The adoptive families were looked at to see if they had high-risk behaviors that would be consistent with schizophrenia. So what they found was that The highest risk was if you had a genetic predisposition and if you grew up in a family where one of the parents was schizophrenic. So, but if you had the hereditary factors that would predispose you to schizophrenia and you went to a family that was normal, the risk of schizophrenia was decreased. So the environment does help. So again, I would say with any mental health disorder, and again, we don't have long-term studies that would verify this, but I think it's pretty consistent with what we already know, is that if a parent has a mental illness and that child is adopted at an early age, goes into a family, raised in a normal family without being exposed to mental illness, those children are going to have less of a chance of developing that particular mental illness than a child who grows up in their birth family, parented by a family who has that disorder. So again, adoptive families can have a beneficial effect on this. Now, that's not to say you ignore it. You can't adopt a child whose mother was a known schizophrenic and say, my child's never going to develop schizophrenia. You have to be very careful, especially during adolescence, to look for the signs that there might be mental illness. Get that child treated early. There are effective treatments that dramatically help individuals with schizophrenia function in society and live productive lives. And those are things you have to keep in the back of your mind, that that's a risk. You know, it's a risk with so many other things that we know about. But again, the optimal environment of adoptive families can help in that kind of a situation.
And another thing that we sometimes see is not the birth parents who have the mental illness diagnosis, but a grandparent, the birth mom or birth dad's parent. Are we correct to assume that the further away, if the parent themselves, now keeping in mind that the birth parent might be young enough and the mental illness has not been diagnosed, but it's the further away, the further back in the family tree, the less likely the percentage. You know, we've already said the percentage is not as high as you might think, 15 to 20% for some of them, and that's just in general, and even less if the child has been raised in an environment that does not necessarily that is more supportive for getting early diagnosis and treatment. So the further away, does that also even further reduce the possibility?
The further away you are, you see dramatic reduction.
Okay.
So for instance, a grandparent would be a second degree relative, 3% and 5% for schizophrenia and bipolar disorder.
Okay.
So it really is, you know, getting down close to what the
Baseline
risk would be in the general population.
Right. And let's talk about ADHD, attention deficit hyperactivity disorder. While you could debate whether that's a mental health disorder, it is a condition, and it is a heritable condition. So how much do genes impact ADHD, and how much does environment? And we, of course, know that both work together.
Well, there is an association, but again, it's one of those multifactorial things that's kind of hard to tease out when you're talking about a specific individual. But when you look at, for instance, a diagnosis of ADHD in a parent, there are so many things besides genetics that can lead to attention problems. You know, any insult in early life, you know, adversity causes attention problems in kids. The other thing is that, you know, anxiety can cause symptoms that are often interpreted as being ADHD. So, you know, I think it's, at least for me, very, very hard to say very much about whether or not a parent who is diagnosed with ADHD, because it's such a common diagnosis these days, is going to have a high risk, you know, whether that child is going to be high risk. Again, I would tell families, good nurture is probably going to help. Again, if you see any symptoms that might indicate a child has attention problems, you know, have that child evaluated and have that child taken care of. You know, many of our kids with sensory processing problems are diagnosed as attention problems. And, you know, it's a very, very heterogeneous causation for things that turn out to be attention issues.
Mm-hmm. Yeah. And as you point out, it's a very common diagnosis right now as well.
Right, right.
Right. The last risk factor I want to talk about is legal risk factor. And I'm going to talk about that probably more in my wheelhouse here.
Sure.
Uh, Most often in domestic infant adoption, when we talk about legal risk factors, we are talking about unknown or unidentified birth fathers. Uh, each state handles unidentified or unknown birth fathers in a different way. It is a risk factor, and you need to work with your adoption agency or your adoption attorney to discuss this and understand how much of a risk factor it is and what you can do about it and how you can work to help identify who the birth father is. It is a risk factor, but it is something that you need to work with your professional to understand more. Well, Dr. Dana Johnson, thank you so much for talking with us today about evaluating risk factors in domestic infant adoption. Let me remind everyone that the views expressed in this show are those of the guests and do not necessarily reflect the position of creating a family, our partners, or our underwriters. Also, keep in mind that the information given in this interview is general advice. To understand how it applies to your specific situation, you need to work with your adoption professional. Thank you for joining us today, and I will see you next week.